So I don't have to introduce Ronald Ghossein. Everybody knows he's our head and neck team leader and the thyroid guru. Discovers many new entities in thyroid, and he asked me to introduce himself as the guy wearing the nicest tie. So there you go.
Okay, thank you, Mira. So let's try not to lose time. So the slide I send you is from a 72-year-old male with back pain. So a CT scan was done. It shows a thyroid mass, a T10 lytic lesion that showed a carcinoma, and the thyroid FNA showed a papillary thyroid carcinoma. So the patient underwent naturally a total thyroidectomy. And the first thing you notice that this is clearly a widely invasive tumor. It was really big, 5.5 centimeter. And when you look carefully, you have really two areas. Some areas where there are two papillae formations with the nuclear features of the papillary carcinoma family of tumor with clear irregular nuclei. But there were other areas where the tumor is growing in solid nest with, again, the nuclear features of papillary carcinoma. But here, the big difference, a detail that usually is not carefully thought after by pathologists, there's a high mitotic rate, 5 mitoses per 10 high power fields. So how to label this tumor? So actually, you'll be surprised that there is no agreement. If you use the definition that we used at Memorial based on a paper that we published in 2006, this will be called poorly differentiated thyroid carcinoma, which means a 60% survival at 5 years. If you use the widely utilized Turin proposal that has been accepted by the WHO as the definition of poorly differentiated thyroid carcinoma, this will not be called poorly differentiated. It will be called papillary thyroid carcinoma solid variant, just because it has clear nuclei. And then this means that the patient has a 90% survival at 10 years. So what happened to this patient? Unfortunately, the disease progressed in the bone. Radioactive iodine treatment did not work. External beam radiation did not work. This was in the year 2000. There was not that many targeted therapy, and unfortunately, the patient succumbed of disease 4 years after diagnosis. That's not what you expect usually from a papillary carcinoma. So this is an opportunity to talk not only about poorly differentiated thyroid carcinoma, but also about how we pathologists label disease and the incredible impact it has on the treatment of patient, on the clinician, and the psychosocial impact of that diagnosis on the patient. So I'm going to start with a statement for Dr. Wallner, who was a pathologist at the Mayo Clinic, and he said that all clinicians used to think that the classification of thyroid cancer was very simple. There was a group of well-differentiated, slow-growing tumor that never killed anybody, and a group of rapidly growing tumor that killed everybody. And I don't know if Mira or David remember, but I remember Dr. Ghossein telling us that when he chose to be interested in thyroid at WashU in the 60s, there was a surgeon he was a junior attendee, I guess, right, David? A surgeon made fun of him, said, "What's a silly idea? There's nothing in the thyroid, just tumor that kill everybody and tumor that don't kill anybody." Well, that surgeon was wrong, and Dr. Ghossein was right. There are tumor in between, and the prototype is this poorly differentiated thyroid carcinoma, which is tumor that has histologic and prognostic features intermediate between the extremely indolent, well-differentiated thyroid carcinoma and the catastrophic anaplastic carcinoma. And we have to thank Dr. Ghossein for putting this entity on the map in 1984, where he described a tumor called insular carcinoma. Insular in Latin means islands, simply solid nest. But what he did actually, and he acknowledged it in his paper, in the title, he actually redescribed a carcinoma that was reported by the Swiss-German pathologist Paul Langhans in 1907. And I think this means it's Swiss-German proliferating stroma. You can see in Langhans' article how the croquis, the drawing is so similar to the one, to the tumor that we call now insular carcinoma. So this controversy about the definition goes like this. Well, first of all, everybody agrees there is an entity called poorly differentiated thyroid carcinoma. And when there is a solid growth pattern, necrosis, invasion, everybody agrees this is poorly differentiated. But the rub, the problem, is what happens if you go you have solid growth pattern alone or mitosis and necrosis alone. What do? Do you grade tumors by architecture vis-a-vis the resemblance to fetal tissue, basically? That's how it works in most tumors. Or do you go by what I would call proliferative grading, what lung pathologists have done for neuroendocrine tumors for a long time. So in order to show you what it means, I will show you two articles on the subject. One done by a very good bunch of Italian pathologists from Torino in Italy, where they decided to define poorly differentiated thyroid carcinoma on the basis of solid growth. That was in 2004. And when you look at the curves, I indicated it in red, really the tumors are in between the well-differentiated tumors, papillary and well-differentiated follicular carcinoma, at the catastrophic anaplastic. But when they develop a numerical scoring system, and the main component of the system is necrosis, that's what happened in their own paper. You have no necrosis, you still are called, poorly differentiated thyroid carcinoma, despite the fact you're doing better than papillary carcinoma. I mean, I don't know if there's it's very difficult for a carcinoma to do better than papillary thyroid carcinoma, to be more indolent. So clearly here, you see how the nomenclature doesn't really match outcome. Now, if you have necrosis, you really do in between the well-differentiated and the anaplastic thyroid carcinoma. So when I saw this paper, I thought, why don't we do something different? I don't know why nobody thought in thyroid of using mitosis necrosis. Said, well, after all, they would do it in lung for really very important reason. And so why don't we try that? And we did it in 2006. We looked at all the cases and tried to group them on the basis of carcinoma, or the basis of mitosis and necrosis, irrespective of growth patterns. So I used a cutoff of 5 mitosis because the paper before said that papillary carcinoma are more aggressive when they have 3 mitosis anyway, and or tumor necrosis, really fresh tumor necrosis. And so what we got is cases like the one on the left here that everybody agrees are poorly differentiated thyroid carcinoma because they have a solid growth pattern. And cases on the right that have papillae, they have follicles, but they have tumor necrosis. So just here, a little practical parenthesis for those of you who sign out every day, that usually these tumors have a mixture of phenotype, like Hürtel cell areas and papillary areas. And until 10 years ago, I used to see reports saying, labeling the tumor papillary, follicular, and Hürtel cell carcinoma. I used to tell the clinician, every time you have a tumor like that, please be sure we review the slide, because that's probably a poorly differentiated thyroid carcinoma. That's what thyroid carcinoma do when they progress. They start to have a jumbled, disorganized phenotype. So when you look at these cases that we classified on the basis of mitosis and necrosis, the 5-year survival was 60% at 5 years, really in between papillary, which is 99% at 5 years, and anaplastic, close to 0%. Now, within this tumor defined on the basis of mitosis and necrosis, so what are the factors that drive outcome? Of course, things like size, margins, and extrathyroid extension are important. But what was more interesting, what did not influence survival, and it's the growth pattern. So if you have a solid growth pattern, a follicular, or a papillary growth pattern, it doesn't matter, really. The tumor will still go toward the same harbor, so to speak. So after these 2 papers, a bunch of pathologists gathered in Torino in Italy, and they came with this proposal, a Turin proposal. They didn't invite me. So anyway, so the thing is that if you follow this proposal, first you need a solid growth pattern. This means you're going to exclude every papillary carcinoma and follicular carcinoma that has necrosis that is very aggressive. You need nuclear features of papillary carcinoma. So just the fact that you have nuclear feature of papillary carcinoma means that the tumor is not poorly differentiated, means that the tumor is not aggressive, which doesn't make any sense. But where I agree with them that they need mitosis and necrosis, and something called convoluted nuclei that I never really understood what it means, but I think they mean attenuated papillary carcinoma nuclei. Anyway, let's look at this data. So this is the paper that is used today. So actually, indeed, they're poorly differentiated, are in between the well-differentiated and anaplastic. But here again, when they stratify by necrosis, actually that curve is not very good because they put here papillary, follicular, but at least these are non-anaplastic thyroid carcinoma, and the one without necrosis do very, very well, like papillary carcinoma. Same thing with mitosis. So clearly here, again, it doesn't make sense. Why should you call something poorly differentiated when it behaves like a papillary carcinoma? So here at Memorial, despite the fact we are in a distinct minority, we still, against the advice of the Abusher, we don't use this definition. We use our definition, and we proved it many times because we did a study and found out that this is the main cause of radioactive iodine refractory disease. Most thyroid carcinoma patients, when they do poorly, they don't respond to radioactive iodine, and it's the cause of death. Finally, also, another reason is that a lot of these radioactive iodine refractory poorly differentiated thyroid carcinoma were initially diagnosed by things like papillary carcinoma, follicular variant. So you have a little bit to put yourself, or follicular carcinoma, to put yourself in the shoes of an endocrinologist. Usually when they read a report of papillary carcinoma, they will tell the patient, oh, you're lucky, you have the most indolent tumor in the human body. When I retire, I will transfer your care to my successor. And he or she will be faced in 3-4 years with a patient not only who recurred, but on top of that, he or she should send the patient to Memorial, MD Anderson, Ohio State, because radioactive iodine doesn't work, and they need really to be in clinical trials. Also, the reason we use it is because we did a study on those patients who died from non-anaplastic thyroid carcinoma, and these tumors were the main cause of death from non-anaplastic thyroid carcinoma. So now, because these tumors really do not respond to radioactive iodine therapy, the only way to hope for treatment is to understand them at the molecular level. And with my colleagues from the endocrinology service, Dr. Jim Fagan, I helped them with this study where they did a kind of comprehensive genome profiling of our series of poorly differentiated anaplastic thyroid carcinoma. So when you look at, if you use the mutation platform that they're talking about, this was at that time, a few years ago, we had only 340 genes. You already see the different mutation rate in poorly differentiated, in between well-differentiated and anaplastic. Even interestingly, the mutation rate seems to drive outcome. As expected, tumors with a high mutation rate within poorly differentiated did worse than those with a low mutation rate. So what are the genetic drivers that make these tumors? So the same drivers that you found in papillary and follicular carcinoma, you also find them in poorly differentiated. Like 33% of the poorly differentiated have BRAF mutation, 21% have RAS mutations. But here you have to be careful. It depends what definition you use. So as we talked about, there are two definitions. If you use our definition, then you will capture the RAS and BRAF tumors. That's why most of the BRAF tumors will be called only by us poorly differentiated. But if you use that Turin proposal, it will only capture the RAS tumors. So basically, to make it very simple, the Turin proposal is an instrument to catch high-grade follicular carcinoma, because all these poorly differentiated are simply papillary and follicular carcinoma that gone bad. While I think our definition captures all of them and is obviously better for counseling and therapy. Now, this is also important because BRAF and RAF have distinct tropism. If you have a BRAF tumor, the carcinoma cell will travel first to lymph nodes, then to distant sites. Where if you have a RAS tumor, it will the tumor will travel to a distant site, bypassing the lymph node. Now, of course, there are other things that play a role, some rearrangements like PAX8, PPAR gamma, and RAT. Not that many PIK3CA and PTEN mutations. Not much P53 mutation, actually, also. I forgot to put it here. Now, there is a gene that was found in thyroid cancer, the EIF1AX, which has to do with the translation initiation machinery. And this gene is mutated in 10% of papillary and anaplastic carcinoma. And actually, in anaplastic thyroid carcinoma. So if you look at the papillary thyroid carcinoma, it's mutated in 1%, and poorly differentiated 10%. And here what was interesting, that you can see that with this gene, you can stratify also the patient with poorly differentiated thyroid carcinoma. Those with the EIF1AX do worse. But perhaps the most promising finding is with TERT promoter mutations. Now, these TERT promoter mutations I found in 9% of papillary carcinoma, but also in 40% of poorly differentiated thyroid carcinoma, and anaplastic even worse, in 73%. Here again, we found out that the cases with TERT promoter mutation, the poorly differentiated did worse than those without TERT promoter mutations. And I will pass on this in the interest of time. It seems that if you have BRAF or RAS mutation alone, it's much worse than if you have, BRAF or RAS mutation with TERT is much worse than if you have BRAF or RAS alone. But I think this is the hope here, is when you look at the TERT promoter mutation in papillary carcinoma, they are subclonal, while in poorly differentiated anaplastic, they are clonal. So that means that maybe they are a key transitional event in tumor microevolution, and maybe we can focus our really aggressive treatment on those papillary carcinoma who have TERT promoter mutation. So here there is a hope to better isolate the bad actors within papillary carcinoma. So basically, what I want the message here is whatever the definition you use for poorly differentiated, of course, most of you probably use the twin proposal. I highly advise you to report on tumor necrosis and mitotic rate in thyroid carcinoma. Actually, even the people who use the twin proposal, many of those who did it acknowledged to me that when they see an aggressive tumor, they put there is necrosis, and they put our paper saying this is bad behavior. But just it's a fight in regard to the name, to the nomenclature, because they are stuck with the philosophy that only architecture should define differentiation.
Your conference is scheduled to end in 2 minutes.
Okay, it will end in 2 minutes. So, for example, if you, but unfortunately, if you look at the College of American Pathologists reporting, they still don't, it's not mandatory to report on mitosis and necrosis. Now, in addition to the College of American Pathologists, there is the International Collaboration on Cancer Reporting, which includes people from all over the world. And now in this one, necrosis and mitosis are mandatory. So beyond the issue of thyroid carcinoma, the message I want to say that I hope we will move from a new nomenclature of tumor from an old nomenclature of tumor to a new one that better reflects behavior. For example, in staging, we moved in the 7th edition from anatomic grouping to an anatomic prognostic grouping. And also, in regard to entities like in thyroid, we can really rely on prognostically relevant histologic features or molecular markers, like, for example, necrosis and mitosis, instead of really focusing on things that are not relevant, like the architecture of the tumor. So basically, it comes with the philosophy that the pathologists should be just clinicians with the microscope and not only histologists. And now, to finish the talk, I always like to put this statement from Julian Huxley. Julian Huxley was a biologist. He belonged to a family of very prominent British intellectuals. And in 1958, actually before I was born, and many of you, he was giving a talk at the Sloan Kettering Institute, maybe in this place, where this building stands. And he said that cancer malignancy must be defined operatively in terms of what the tumor cells do, not what they look like. Otherwise, the term ceases to have biologic meaning. And we can also export this to the molecular biology. Sometimes they put, they label tumor based on a translocation without really telling us what does it mean to have this translocation. I think that's it for today. Thank you so much.
Thank you. Anyway, the theme of afternoon is what's in a name. So we have to think about that. So the dinner is at River Park. I guess people know where it is. And I want to just thank Simone Ramkison, who's Dr. Klimstra's administrative assistant, who arranged all the conference and then bugged everybody for their presentation. So I would like to really thank her for her effort. Okay, see you at dinner.